Hello and welcome everyone. People are still streaming in. We'll get started momentarily here. Thank you everyone for realizing that this was not an April Fool's Day prank and a real webinar and showing up. Okay, let's get started. Before getting into any meat of the contents, very brief housekeeping. We want this to be an interactive session. There is a Q&A box where you can submit any questions that you have. There's a chat box that we will also be monitoring. We will answer questions that are really salient to a current topic as much as we can in the flow of the conversation. We do have time set aside at the end to answer as many other questions as we possibly can. The webinar is being recorded. We'll send out a summary and notes, so that will be posted within a few business days. We will send out the deck that you are looking at currently, and that we'll use to guide the conversation pretty soon after. So this there's a few slides, a few pieces of information that are denser, that are meant to be a resource available and not really discussed in the webinar. So all of that will be available very soon after we finish this. Let's quickly introduce the faces that you are seeing on your screen. First, we have Marc Ryan. Marc is Lilac's Chief Solutions Officer. Prior to Lilac, Marc was the president of MHK, what many of you might know as MedHawk. And Marc's healthcare experience is really extensive. So before MedHawk/MHK, he was an operator at health plans. He has launched plans across Medicare and Medicaid. Even before that, he worked in healthcare policy in the government. So really knows healthcare from every side of the ecosystem. Welcome, Marc. Thanks for joining.
Thanks, Alex.
Next, we've got Neetu Rajpal. Neetu is Lilac's CEO. Prior to Lilac, she was the CTO at Oscar Health. And before that, very extensive experience in building enterprise software, very complex systems, from APIs to front-end applications. So really well-rounded experience in building software and building organizations that build enterprise software. So thank you, Neetu.
Thank you, Alex. It's great to be here.
And we also have Dwight Pattison. Dwight is an executive advisor at Lilac. Dwight has really extensive experience in healthcare quality and HEDIS. He has it across many different health plans. Dwight led United's HEDIS reporting in its Medicaid division. He has been a consultant and advisor for a lot of other organizations and fortunate organizations like Lilac. So brings a real depth of expertise on stars and everything that touches on healthcare quality. Thank you, Dwight.
Yeah, thanks. Glad to be here.
And myself, my name is Alex Schaefer. I'm Lilac's Chief Commercial Officer. I will serve as the MC for today. And before getting into sort of to set the stage before getting into the actual content, why are we talking about this topic and why today? Lilac, we have a really powerful star management platform. We work with plans in everything from forecasting and really just looking at big picture of understanding what performance is going to look like, down to helping drive improvements across different measures. And one of the questions or one of the themes that come up really consistently in our work with plans and just some of our conversations with other people in the industry is just trying to make sense of everything that is going on with changes in the STAR program. There's a lot that's confirmed. There's a lot that we know that's going to happen. And there's a lot of turmoil, a lot of uncertainty that we're asked to help to sort of figure out how to get ahead of. And we figured, let's bring this well-rounded group together to share perspectives and share some of the big things that we think are really most important for health plans. And so going to one of those slides that's really meant to be a resource for you to digest more, just have available after the fact. There is a lot in the STAR roadmap that is confirmed. There are changes that are coming up that everyone is preparing for. We're going to go over some of those, some of the major ones. And then there's a whole long list of other potential STAR changes that are being discussed, that we're intuiting are possible, or there's some degree of possibility based on some of the things the Trump administration and some of the healthcare officials who are sort of starting to take their seat and starting to roll out the beginnings of a policy paradigm, really trying to understand what this might mean. So there's a lot that is going to happen. There's a lot that might happen. And we're going to try to cut through a lot of that noise and share what we think is most important. And so we distilled all of that into 5 major themes. We're going to go through each of these 5 in a sort of a semi-structured conversation. We're going to talk a little bit about what we think are the most important takeaways, what are the most important things to be aware of in each theme, and then unpack a few adjacent subpoints. So first, we'll talk about universal foundation. Then we'll go into measure weight changes. What are things coming up, and how is that going to affect maybe your resource allocation and your overall STAR strategy? Health equity index, really big topic right now. So we'll go into what it is and what some of the tea leaves are saying how that might evolve, or how it might roll out or not roll out. Then we'll talk a little bit about the 2026 rule status, and just with the administration changes, what might the effects be, and then the move to ECDS. And so we'll talk about a lot of sort of adjacent topics as we're going through each of these, cover as much ground as we can, and then last 10 or so minutes will be open to Q&A. So please do be adding questions to the QA box or the chat box as we're going through this. Without further ado, let's kick things off. And Dwight, I'm going to hand it over to you to lead the conversation around universal foundation.
Great. Hey, everyone. I asked to talk about universal foundation today because I think it's an interesting topic, and I think it's going to help us keep track of the things that might come into STARS in the future. And I think it's really important that we, as folks that lead STARS programs or have influence over STARS or have to adjust to what's coming, there's always these little things that come out that say, hey, maybe this is a direction they're heading into. And universal foundation is a pretty interesting idea where in 2023, CMS put forth a strategy to align measures across all of their programs. So they've got measures with provider organizations and hospital systems and payers, which we're talking about, STARS for Medicare, quality rating system for exchange, you name it. And so they came out with a list of initial measures, and they said these measures would change over time as those get evaluated. And so they came up with a child measure set and an adult measure set. Here you can see the adult measure set. And really what's most critical is the idea of that conceptually they want to get measurement aligned from program to program. Right now you might have a diabetic A1C measure that has slight variations in the methodology. So you've got provider groups responding to CMS directly or other internal programs, where you've got the payer asking for something different. And without that standardization, it's waste and it's confusion. And why not have standardization so we all measure the same thing? We're focused on improving the same things, so we have the same goals, initiatives across wherever those patients' members are. And this is the list. What's critical for STARS is there's several measures that are not yet in STARS, but as you've probably been aware, that they've been proposed for future inclusion. So you've got screening for depression, you've got initiation, engagement of substance use for disorder and treatment, and then you've got social needs screening, which is social screening for social drivers of health. And what we take about that is like, hey, I used to say like these are guaranteed, they're coming, right? We can expect that, but we do know there's now a new administration within the last week or so. The exchange program, the proposed draft call letter for the 2025 measurement for the quality rating system under the exchange product just came out. And guess what? They recognize that social needs screening was part of the universal foundation, but they've decided to remove that measure from the measure set, basically stating that they're going to align their agency's priorities, and that's not in them. So what you can expect is that this is going to be likely a driver in the future for standardization, but which measures are going to be in that list are going to change with the administration, maybe future administrations. So you kind of have to keep track of what's happening, what's changing. We're certainly going to get some hints in the next month as we get regulation updates, and they're likely to start changing and updating this. But conceptually, regardless of which administration's in, Universal Foundation is about streamlining measures, getting and focusing on specific ones, aligning across organizations. I think that's an efficient way of operating in quality, and I think you're going to see that lean through in the current administration. It's just which topics are of priority are going to change, and there are going to be slight differences. So we'll hold on. We won't say exactly this list is it, but we'll certainly expect that this type of concept and standardization is going to come through Medicare and the other agency programs as well. Marc or Neetu, do you have any thoughts specifically on Universal Foundation and its effect on stars?
Well, just real quick, Dwight, I think you're absolutely right. I think it's a good move from a policy perspective, something I always look at. Again, there are so many myriad pilots out there, whether they're provider pilots in fee-for-service or with health plans and even across different lines of business. So efforts to sort of streamline, get to the same methodologies and get to the same base measures, really important. I do feel like every population group is slightly different, so you may always have some measures that may be specific to a program, but anything you can do to reduce admin and really get to a point where you can look at quality across all of the populations is pretty key.
Yeah, good point.
Yeah,
I think, go ahead, Neetu.
I was just gonna say I'm actually kind of excited about I know there are like multiple studies that talk about Medicare Advantage and if it's been helpful or not, but I think overall it's actually helped quite a bit in bending the cost curve and improving outcomes. And there's always improvements that you can make across the measures and across calculations, but being able to bring that level of very large impact to everything is quite exciting.
And yeah, it will be exciting. And I think the idea also is that we might see reduction in measures, which actually the Biden administration proposed in January, removing operational measures. Some people may celebrate the loss of future idea that maybe telephone screening might go away. But actually, you got to be careful. Those measures actually perform pretty well for most plans. That loss of operational measures could be a huge loss in your scoring. So what might feel easier and streamlined may actually have a negative effect on your organization over another. My recommendation always for organizations is the minute you have an opportunity to comment on these changes, you need to submit them to CMS, NCQA on measure changes, PQA on pharmacy measures. Like, you've got to get involved in influencing the decisions, because that does matter. It does have an impact. These are the strategies that start formulating your future programs, and get involved and certainly keep up, and we'll keep up to date and notify you if there's additional changes as we go.
Right, that feels like a good place to end on that topic. Let's move on to the next big theme and measure weight changes. And Marc, over to you.
Great, thanks, Alex. We really wanted to cover this topic here today because I think we're at a point right now where there is so much change going on in STAR, right? And I'm thinking from STAR year 25, looking out to 26, 27, 28 as an example. So we're always used to some weights changing in measures and maybe a measure or two that pops in and things like that. But if I counted this right, more than half of measures moving forward are being impacted, so well over 20. And that's because the weight is changing, and that could have impact, and some brand new measures being rolled out, from 24 to 25, 26, 27. So it's really a major change that plans are looking at, and we hope that you've prepared for that and you've thought about it, right? The biggest one we're seeing from 25 to STAR year 26 is the fact that the CAPS measures and the member-focused ops measures are being moved from 4 down to 2. That's about 16 measures. And what that actually does is moves sort of the general weighting, if we can call it that, in groupings from those CAPS and member-focused ops measures to clinical measures, NCQA HEDIS clinical measures, drug measures, and the HOS measures. And we also have some introductions of new measures too, like 2 in HOS, a couple of new measures in drugs coming in, the risk adjustment for med adherence coming in. And we have a brand new kidney measure as an example too, that's just come in, that's gonna, have to evolve as well, which is a little more strict than the previous neuropathy measures because you have to look at urine and blood. So all of this comes together to say that there is this transition coming, much more focus on clinical and drug measures and some HOS, and whether that is positively impacting you from a weight perspective is really dependent on how well or how poorly you performed previously on those 16 measures with weight changes. So what plans really need to do is they have to move forward and really assess what that weight change happens and begin looking at how these other changes in the clinical and the drug and the HOS world are really impacting you. Drug measures in our mind is really a source of pain. If you look at the STAR measure ratings, they're not very high. And we have these 2 new drug safety measures come in, which are very tough. And so you also have the data lag, depending on how you're doing it. You gotta stop that data lag in drug measures. We'll probably have a future webinar on excellence and best practices in drug measures. So investing in analytics and reporting right now to assess all those changes is very, very key. So I'm gonna stop there and just sort of maybe, also we have colorectal cancer screening too, which I know Dwight focuses a lot on. And Dwight, I'd just like to throw out this question to you. You've been in the business for a long time here. And have you seen as much activity as we're looking at? And what do you really see as some of the risks that plans have to look out for here?
Yeah, it's odd. I mean, we went through a period of time in STARS where there weren't that many changes. They weren't as dramatic. So you sort of had a stable program where you knew what you were going to do. You knew your Achilles heels. You tried to focus on them. And all of a sudden they threw out, higher weighted measures and CAPS. And there was a whole new excitement in CAPS that I used to, as a consultant here, plans say, well, I'm not, we can't move it. So we don't focus on it. And then all of a sudden it's like it's higher weighted. And now they're putting energy and resource. And I think you can't lose sight of that. My take is this, like everyone's plan has, whether you want to be a 4 or 4.5 or a 5, there is a path of points and numbers. You can't ignore any one measure because there's effect, but you definitely want to make sure you look at the idea, like the weighting matters. There's more emphasis on HEDIS. What I see as a challenge this year is there's not enough focus on the HOS measures. You're going to be surprised. There's a 1-weighted measure of the improving or maintaining health status for mental and physical. It's 1-weighted. It comes out in STARS 26. It's already happened. Now you've got STARS, the survey coming out this July, and it's going to be 6-weighted points with unknown values and unknown benchmarking because the measures have changed over the last few years in display results. So you've got a huge amount of work on member outcomes at your whole population level. So when we think about measure weight changes, it does change your strategy. You have to, at a very least, every 3 to 6 months, stop, look at the new regulation changes and say, is our strategy on track? Are we tactically addressing each measure correctly? Are we seeing the goals met we need? And you have to have a 2 to 3 year strategy that looks at new measures because it takes a long time to implement new programs, get them into your value-based care and the like. So definitely weight changes now should have been planned before, new measures changes. Like you kind of have to be a couple years ahead of the game to succeed. And then we know there are other changes happening. So you got to keep the stability in your base scores and focus on these new changes to help sort of.
Yeah, it makes a lot of sense. And before we go to the next one, I'd like to throw one to Neetu here as sort of the expert in technology. This will apply to our segment coming up on HEI, but you take HEI and all the changes here, And it becomes a little bit of a nightmare and a huge complexity for individuals to really oversee. And there's a lot of talk about AI and agentics and things like that. I don't know, Neetu, if you could just very quickly point out where sort of AI and those kind of things can start to help plans over time really grapple with all the complexity.
Yeah, thanks, Mark. I'm pretty sure I've never talked to any STARS leader who wishes they had more spreadsheets to work with or more calculations to do. And I'm also sure you've not worked with them either. I think the number of changes and the pace of changes combined with the amount of data that people have to look at to clearly identify the right strategy to then go execute on the strategy. All of that is a lot of steps, and a whole bunch of them can actually be handled just by analytics and having a robust system or something that helps you figure out the right set of things that you should be focusing on. I've never met a STARS leader who has more resources than they want. I've never met a STARS leader who is always up to date on their list of things that they have to do. I think there's a lot here that can be done by something that just calculates things for you and points you in the right direction, gives you the data at your fingertips that you can then execute on. There's enough to do, and figuring out all of the data behind the scenes shouldn't be one of the things that people have to do. So
Great. Well, thanks, Neetu. I'll turn it back over to Alex here. I
Yeah,
think
yeah,
we're good
that's
for the
great.
segment.
And yeah, the potential of AI and agentic AI in particular, very hot topic. So that is certainly going to be a theme we're going to be exploring more and more, and something we're doing a lot in obviously our product development. But let's move on to the next big topic, health equity index. Neetu, back to you to give a little bit of an overview.
yes, I created this slide just to really illustrate the analytics and the things that you have to keep in mind. Health equity index and health equity index is replacing reward factor this year. This already kind of went into effect last year with the measurement, because health equity index is a 2-year blended calculation. It is 2-year blended calculation that applies to a subset of STAR measures, and it actually applies to a subset of STAR measures that have the right level of SRF population in your plan, and also across overall the whole market. And then depending on all of that, it depends on how the whole market did as to if you get to calculate that or not. Either way, wanted to just highlight the layering of statistics and calculations that go into calculating what your health equity related adjustment might be for your overall STAR score, and only some of it is under your control. So the table at the right is pretty much all the possible combinations that will help you calculate the 2-year blended calculation for health equity. It depends on how the whole market did. It depends on what your score is for a measure over the past year and what the delta is between last year and this year, and also what your overall enrollment was that has social risk factors and is attainment for that particular measure. Anyway, lots and lots of like layering and layering of calculation for how to actually determine health equity index. Very complicated formula on the bottom left, which applies to most measures, but not all measures. As you can see, this whole topic can turn into a whole new webinar in and of itself. So I'll spare you that and just say health equity index, very complicated calculation. I think it dramatically increases the level of attention that you have to pay to each of the measures. But as Dwight always reminds us, at the end of the day, if you just pay attention to the gaps that need to be closed for your member population, and you pay extra attention to the population that's been underserved, and prioritize that population and pay attention to how they actually like to be communicated with, That is something that is going to overall improve the health equity index. You can do all the calculations. You can have, some partner help you with the calculations, but at the end of the day, it is really about closing the gaps with all of the members that are in a underserved population or that have complicated health situations. With that, I actually have a question for Marc, because this is a question which is the elephant in this room right now. Given the current administration's stance, and Marc, given your past experience being the budget director for Connecticut, what do you think is going to happen to health equity index going forward? Like, is it going to stick around? What is your take?
I think that's the $1,000,000 question, or as some of us older guys used to say, the $64,000 question from the quiz show many years ago. There's sort of a bit of a rub here, and having been part of transitions of government in the past, there's a whole lot of stuff going on in the first 4 or 5 months, which means that you got to prioritize the things you go after. So oftentimes you're still searching months and months later into exactly what's happening in government. So I think you do have that phenomenon as well that is always part of the foundation. So maybe the HEI is not, going to go away just because there's so many things a new administration has to do. On the flip side, though, we know that we lost our slide deck there. Sorry, Alex.
Yeah. Sorry.
Just saw that there.
Dwight got kicked out somehow and
Got
trying to
it.
troubleshoot, but it doesn't look like that's
Understood.
Sorry.
We know that HEI is a extremely sensitive issue for the administration. They have been basically closing down diversity type programs. They've started to expunge even the name HEI out of government lexicon, as an example. So that might be a good sign, not a one I support, of course, but it might be a good sign that they may actually come after the HEI, right? And they've already sort of done something similar in Medicaid, where on SDOH, they basically pulled back on that process of quickly putting through SDOH waivers in Medicaid. So in yet another sign, right? However, the HEI does save money for the federal budget. It was estimated to save about $700 to $800 million in the first year because of the difference in payouts between reward factor and HEI qualification. And then over 10 years, it's somewhere around $5 billion. So you have the savings they would give up and some of the political motives that they may have. I tend to think the politics may override the savings, but we're not quite sure yet. So I think there is a possibility anyway, if not a probability, that HEI could be targeted, but they got to make up that savings when they're trying to save a whole lot in government to pay for tax cuts. So Neetu, that's probably the best I can give you right now on what might happen here.
No, that's probably the best we can all come up with at the moment. So thank you, Marc. Back to you, Alex.
Great. Okay. Let's move on to the next topic. And speaking, Marc, good segue almost into just changes and what some of the impact of the new Trump regime coming into power and rolling out their policy and their agenda. So why don't you start us off?
Sure. We just wanted to highlight here really quickly that, as everybody knows out there, there's really sort of 2 documents, I'll call it, or 2 processes that really tell us about what that STAR roadmap is going to be. The first is really the annual rules, the Medicare Advantage and Part D rules. And within those rules, CMS is proposing in regulation changes to STAR. And it sort of gives you a look at what's going to happen over time. And then we have the advance and final notice process, which is largely focused on rates. But within that advance notice, there's a lot of STAR material in there, basically telling you exactly what's coming in the next STAR year and then giving you a feel for what's going out over time. And the two of them really have to be looked at together. One of my criticisms of this process, it's pretty opaque. You gotta always track year to year. Things can change. You gotta read thousands of pages of documents to really even set what the roadmap is going to look like, and then it could change at any time, to be honest with you, as well. And so I would really love to see CMS, because quality performance is going to be a very important part in healthcare, to really find a better way to do it. We always need rules. We always need to say what's happening next, but can they bring more transparency and take some of the confusion out of it is really important. So the rule was proposed in November. It should be finalized sometime in April by the Trump administration. Proposed by Biden, has to be finalized by Trump. The notice was filed in January by Biden, and Trump will have to finalize that in April. So we'll probably see a lot of changes in both of these, right? Will they come to STAR? It's unknown. HEI is in the rule, so that could be on the hot seat, and we might see some things happening there. 2 new measures were proposed in the rule. Will they stay? Initiation of substance abuse and initial opioid dosing. They do propose to remove guardrails. We'll be watching very closely for whether that stays or not. I will tell you, there are pros and cons to guardrails. Sometimes plans will be helped by the removal. Other times they're helped by keeping them. And so there's also a lot of discussion on retiring measures, as Dwight pointed out, the operational measures, and some even new measures coming down the road, some related to universal foundations. So we really have to watch this, because there's going to be a lot happening. I tend to think you'll see some changes in the rule, but then as the Trump administration keeps going, you'll see more changes coming down the road with supplemental rules, or especially the rule for 2027.
Yeah, I really wish we could relabel and follow Google's lead and relabel things to non-medical determinants of health. Maybe that will help.
That could shelter some of these things. I think you're right, Neetu. I mean, as you know, I'm a fan of tackling social determinants of health, because there is so many studies out there that say it can actually be a greater predictor of outliers in outcomes if you tackle those social barriers versus just concentrating on medical. And it's very unfortunate that SDOH and HEI have become bad words in essence, because it's actually very good policy.
Yeah.
And we're saying also fulfilling the mission of healthcare. This is a big part of why everyone is drawn into this industry. It is to make an impact on the people who need it the most. Create a system that is, whatever branding you want to call it, but equitable and fair, and gives everyone access to healthcare. So hopefully, at the very least, the principles of HEI in particular sustain with whatever all the other changes that happen. Let's power on. Let's go to our last topic. And apologies, Dwight, there's some technical difficulties. This is, the fun of a live webinar, trying to get it back on for the tail end. But Marc, why don't you take us through the transition to ECDS?
Sure. We wanted to highlight this one because, again, this is the other big challenge out there, right? And at its base, it's a great idea, right? We want to sort of stop the manual chart chasing and that kind of system and really move toward interoperability. So CMS and NCQA have been sort of plotting this course, and, over the next several years, theoretically, they want to be fully interoperable. They want ECDS in measurement, and really to retire the chart review process. I would also tell you that the parallel process in risk adjustment, I think, may be going away too over time, and everything becomes fully interoperable. But again, I think the main focus here is to improve data quality, advanced technology, advanced data aggregation, and the amount of data that's available really to free up between providers and payers. So fundamentally, it's a very good idea. The reality, though, is that most plans are perhaps really not ready for that. On the next slide, I think you can see, I won't go through all this here, but you can see the NCQA and CMS strategy toward bringing things in. We already see in measure year 24 colorectal cancer screening, and we are predicting a very major drop in performance of that measure, probably more than 5%, but the guardrail will cut it off at 5%. So that's sort of a positive, right, in terms of what guardrails do. But we will continue to see the retirement of manual chart review and then ultimately conversion to ECDS. And you're going to have probably some plans that have invested here in a much greater way. Those that are probably integrated with health systems or are actually owned by a health system, those plans probably have a better way of sort of getting down this road of ECDS because it's all in one roof, or they have very strong relationships. What will probably occur is, in general, performance on measures will drop initially, and it will have to recover over time as all plans begin to do better on ECDS. But I think the big vulnerability here is the plans that have not made the investments or are not highly integrated with health systems and things like that, where they can tap directly into EMRs, or in states, for example, that have rich health information exchanges may do better as well. I almost said HEI, but it's an HIE. So there are some plans that have some advantages that will probably have better uptake initially. Other plans with more IPA models may struggle, and that could really hurt them in the process. I happen to believe, again, great idea. We may be going a little too fast. There may be a lot of fallout in STAR with some plans. You may see NCQA and CMS backing off a little bit on this, just given everything that has to be done. But overall, it's the right way to go. We have to move toward interoperability. It's sort of a forced investment in interoperability in essence here. And I think there are other dividends that will be paid over time as well.
I think one of the
Go ahead, Neetu, sorry.
Yeah, one of the things I wanted to highlight is like it's definitely interoperability, and it's definitely access to all of the data. One of the things that I think we sometimes don't talk about as much is the going away of sampling. Like, if there is no sampling for HEDIS measures and all of the population is now in play, there are definitely like learnings and practices people have in place that like optimize for sampling. And if that goes away, it does require the need for having a year-round review of all of your records and having fast processing behind it, because I cannot imagine a person doing all of that stuff manually. So I think it's like seriously, and this may be the year where that like gets highlighted with colorectal cancer, because that is actually significant amount of hybrid effort there. So I just wanted to like highlight that because I think it's very important, and it like kind of doesn't get talked about all the time.
Absolutely. Great.
That's that is all the planned content. We have a little bit of time for a Q&A. There's a question going back to HEI. What do you think plans with low diversity in their membership do to compensate?
Yeah, let me try and start off there, and I'll hand it over to Neetu. And I think what the questioner is really talking about is probably with HEI and the reward factor converting to HEI, and sometimes very high-performing plans, regardless of how diverse their population was, got a reward factor, and some of those will lose it unless they also qualify for HEI. And just to go through it a tiny bit, again, the amount you're eligible for is still 0.4. That's the upper bounds for each program. But again, non-diverse plans lose the reward factor potential. Highly diverse plans, if they perform well, can get up to that 0.4 reward. And so, you know, there's many plans that have now said, I'm not diverse enough to qualify for the HEI. They're below, you know, sort of half of the median, which is somewhere in the 20% penetration range, or they're in the 0.2 eligibility, but they would love to get to 0.4, and they are modeling out some attempts to try and drive and become get more individuals with low income subsidy status or dual eligible status or disability status. We see a lot of investments in D-SNP products. And that is one way, certainly, beyond getting into geographies that perhaps are more diverse, that increase your HEI SRF penetration. But there's also a product orientation, too, that could be done. There are a lot of investments, again, in dual eligible SNPs. And if you do create a D-SNP, that could certainly increase the diversity of your plan's population overall in the contract, and perhaps get you to qualification. Caution, however, just know that the SNP rules are becoming much greater. And so as much as people are investing here and they see potential reward here, just know you have to have a very good compliance and care management regime to succeed in SNPs as well. So there's a little pros and cons. But I hope I was able to answer that question. Neetu, don't know if you have any comments there as well.
I think it was very comprehensive. The only other thing I'd add, and this isn't directly under most STAR leaders' purview, but maximizing, like diversifying the actual enrollment population, like making extra efforts to include population that will help you qualify for HEI. So I think that like achieves the overall purpose of expanding high performing plans and access to high performing plans to underserved populations.
Yep, I think that's great. And you keyed me in on another one. Investing in member satisfaction could be very important too, right? Because that may help you keep some more of those diverse populations. And in the dual eligible world, although enrollment, the ability to change enrollment is changing, they do have greater opportunity to go in and out of plans. So that's a great point.
Yeah.
Great. Well, we're pretty much at time. Neetu or Marc, any final words? Anything you want to close out with, or should we just wrap it up?
Well, no, I thought these were great topics to cover. You know, as we mentioned, we'll probably be going deeper into different kind of measurement and some best practices, but it's really a interesting time for plans in STAR. I say we've had 3 years of downturn in STAR from the 22 peak, and a lot of challenges coming up in 26, 27, and 28 for plans to get their arms around.
Yeah, I'd like to say thank you to everybody who's attending, and we've tried to cover a large number of topics, and I'm certain some of those deserve like a more amount of time and more detail. We'd appreciate any feedback that you have in terms of what other topics you'd like to see a conversation around.
And yeah, and that's maybe a good ending point where we'll send out some follow-up material. We'll send out the deck. We'll send it with some other materials. We'll send out. We'll post the recording and do some just the note summaries, and we'll share all that material. We have a few articles planned where we'll go deeper into a few of these topics. And then, yeah, we will start to run these webinars more consistently and go deeper. This was, we went sort of broad and narrow in this webinar. Hopefully it was useful for everyone who listened, who joined. If you want to learn more about Lilac, go to www.lilacsoftware.com. If you want to engage with us, and just, we're very open to having conversations around, just be exploratory, whether we can help, or just be a sounding board for some of the challenges that you're facing. So thank you for the time. We'll wrap it here and expect to get some updates and additional content pretty soon. Thank you very much, everyone.
Thanks, everyone.